Hello, we're having a CCO Club webinar number 99, and this is an interesting topic. I think sometimes we just need to sit back, look at the disease process, look at the codes involved, and kind of encompass everything we need to know about a common disease. So, a question had come out regarding COPD, emphysema, and pulmonology. So we decided to kind of unpack that and give you content that you need to know whenever you're dealing with codes regarding COPD, emphysema, and looking at the pulmonology system. Note that COPD is referred to as an umbrella with other disease processes like asthma and like bronchiectasis and emphysema, things like that, all under COPD. So COPD itself is a broad term, and it is in the pulmonology system. However, we also want to keep in mind that when anything happens to the lungs, other body systems are affected. The first thing we want to just do a quick review of the disease process. Whenever you're dealing with COPD, there's two things that you have to ask yourself first. Is it an acute exacerbation, or is there an infection that is involved? Now, what happens, of course, is that the person already has a constricted airway, a chronic constricted airway of the lungs. And an acute exacerbation means that they're having more difficulty than regularly they would have on a day-to-day basis. When that happens, the acute code is used J44.1. Now, if a person has COPD, everything's going fine, and there's no other information regarding their COPD, the code is J44.9. And that's such a commonly used code because there is a large population of people that have COPD. Therefore, you might want to jot that down in your notebook and kind of have that as one of your memorized codes. COPD, unspecified, meaning nothing else is happening. Then, if you have COPD, you have an exacerbation, but the exacerbation is caused by an acute lower respiratory infection. That's a different code. Then we're going to J44.0. Now, acute exacerbation, the provider will put that on there. They'll say it's an acute exacerbation. And if they list a respiratory infection, note they're probably going to go ahead and identify what the infection is. They may not know right away, but you'll see that in the documentation as you go along, that they are checking and they're running a test to see what the organism is. And once you find out, then you'd be able to add that code as well. What happens if a person has an acute exacerbation and that respiratory infection, the lower respiratory infection? Can they have that at the same time? Well, yes, they can. Then what do you do in those scenarios? Do you just use the J44.0 because that is the COPD and they've got the infection? No, you can actually use both of these codes together. So you would code J44.1 and then J44.0. So we have COPD, we have, and it's in an exacerbation state. And in addition, we have a lower respiratory infection. And we may have a code to identify what that respiratory infection organism is. So, boom, three codes right away. There could be some other codes that are applicable. What if the person is a smoker? Then you're going to append that code. And you probably have already noticed in your manuals, when you look at anything regarding a respiratory code, it's going to have those additional codes to let you know that are they exposed to nicotine or smoke of some kind, or are they a smoker or a history of nicotine dependence, etc. So that's a given. And you would always append those if they're applicable. If the doctor lists that as a history of smoking dependence or nicotine dependence, or they're a current smoker, or they've been exposed to cigarette smoke, keep that in mind. More codes. Now, you could have a patient that has a COPD exacerbation and an asthma exacerbation. There's actually codes for that as well. Note that asthma does fall under that COPD window. I didn't pull out this time any asthma codes. I kind of went with some higher level uh, diagnoses because we were looking at COPD and emphysema, but there are other codes like respiratory infections and asthma that are not going to be as high level codes, meaning the disease process in my mind is not as severe. When we move on, think about bronchitis. Bronchitis is actually also another form of COPD. You might not have been aware of that. Now, I you'll hear me talk about this because this is what I grew up with, bronchial asthma, and it's all locational, and that's why they give it a higher definition or of specificity. When you're looking at the disease process for chronic bronchitis, we need to first look at the signs and symptoms. There's a difference in the types of bronchitis, the chronic bronchitis. We have simple chronic, which would be J4 1.0, but then we have mucopurulent, and that's J4 1.1. Now, what's the difference? Let's look. We have a productive cough in simple chronic bronchitis. We do have sputum and there's no airway obstruction though. But then when we move into the mucopurulent, that means that in that sputum, there's actually pus, which would mean some type of infection. And you would identify the infection if you are able to do that, just like we did with um, the COPD once they've developed an infection and they'll do a culture or something and find out what that is. Now, if we do not have a specificity as to the type, then J42 is going to be our code. And that may be in the initial process, that may be the code that you'll be using because there needs to be more testing done to determine the specificity. Again, everything that has to do with exposure, you're going to include. Emphysema, I think, is not as understood sometimes. It is the kind of the last stages of COPD before you get into things like respiratory failure. Emphysema is a structural change of the alveoli in the lungs. So the lungs in COPD are getting constricted and obstructed, but once you move into emphysema, there is a breakdown of those little sacs themselves. They get hard and they break down and they just can't do their job. Well, when we are identifying emphysema, we can identify where it's located at. Now, we all know we have different lobes of our lungs. We have I think the right side has three and the left side has two. I can't remember. Sometimes I get them confused. But look at the part of the lung to be able to identify which code is the proper code. If it's panlobular, that means that the acinus is already having destruction, J43.1. If we have dilation and the destruction of the bronchioles, that's centrilobular, J43.2. Peripheral lobular is other emphysema, J43.8. Peripheral lobular is pretty common when I'm auditing charts. I see that identified more than panlobular and centrilobular, and it's actually other emphysema. Now, the code set is going to state that other means we've identified it, peripheral lobular, but we don't have a code for it. The code set doesn't have a code, so it would be other, J43.8. But emphysema unspecified, a lot of different titles of emphysema fall into that. We have bullous, let's see, emphysema bleb, vesicular emphysema, etc. That would be J43.9. So anything that isn't identified in our first three boxes, panlobular, centrilobular, and other would, if it doesn't fall in that, then it's going to go into unspecified. What about bronchiectasis? Bronchiectasis is really unique. It is somewhat it's under COPD. It's an obstruction again, but I would encourage you to go ahead and look up bronchiectasis, and it can have infection. And if you do get a lower respiratory infection with bronchiectasis, it's going to be J47.0. Then we'll identify the organism as soon as the cultures come back and we're able to. That also allows for acute exacerbation, J47.1. Remember, I said when we have an acute exacerbation, it means the patient it suffers from bronchiectasis, but all of a sudden it's taken kind of like a turn for a worse, for the worse. We're struggling. The patient's not able to get air in, and of course they'll end up probably in the ER. If it's uncomplicated, nothing else going on, J47.9. You might see the provider stated as controlled and uh, are under good control. I've seen that, or stable. Well, when we've gone through all of these other stages, what happens? The lungs just can't keep up, and you end up in respiratory failure. Now, respiratory failure doesn't mean you stopped breathing. That's kind of a misconception. If someone says, "Oh, they went into respiratory failure," well, that it just means that the lungs cannot keep up with the demand. Chronic respiratory failure with hypoxia is going to be J96.11, and then hypercapnia, J96.12. And you can have both of those. I believe there is a combo code for that, J96.13. Double check that, look that up. And if it is, these are codes that, especially if you're working ER charts, that you'll see pretty often. Now, we can't forget those status codes either that are pertinent to the care of our patients. What happens if we end up having to do a tracheostomy because of respiratory failure? That would be a Z93.0. Usually this is a temporary basis, but we won't get into a lot of inpatient codes, but I wanted to make you aware of them so you can jump out, do more investigation into the scenarios. And keep in mind, if you have a scenario that you would like for us to look at, feel free to let us know. You can put it in the club and we'll code that out for you. Don't forget, it needs to be redacted if you send us anything, but you can give us the highlights. And this would also be a great time, you saw pop up on the screen, if you have a topic request. Say you want to have a case study coded out for a person that's recovering from respiratory failure. What would that look like? And some of these uh, diagnoses end up being with the lungs. There's not much you can do. Um, there are treatments to kind of alleviate and help a person breathe. We're going to talk about some of those medications and things. However, there's no real procedures to repair the lungs. The lungs don't repair themselves. Then ultimately, if a person has emphysema, then you might be a candidate for a lung transplant. That's Z94.2. Now, that code will stay with the patient. Can they still have other lung conditions after that? Yes, because for one reason, you may only get one lung, or you may get two lungs. If you're interested in pulmonary uh, diseases that are high level procedures that can be done, like lung transplants, it's pretty fascinating what they do. But the Z94.2 from that point on will stay with that patient. On the disease process, another area that affects the pulmonology is acute pulmonary embolisms and chronic pulmonary embolisms. Note that your starting point for acute is going to be your I-6 codes. Why would you be using I codes, do you think? Because it directly relates, it's a blood clot, and so it's an ischemic type disorder. That's why we're using an I, but it affects the lungs. So we have a clot within the vessels of the lung that are oxygenating the heart. Chronic is going to be your I27.82. Again, when this happens, whenever you're dealing with any type of embolus or thrombus disorders, the patient's most likely going to be on anticoagulants, Coumadin, Warfarin, Xarelto. I type that all the time, but yeah, Xarelto, I think that's how they said it on TV. In that situation, then Z79.01 would be appended with the patient too. So keep that in mind. That is one of the common treatments for the clots that the patient might have. Now, there's all kinds of cardiac issues that they would be on anticoagulants, but when a person is dealing with embolisms and thrombosis, they're on anticoagulants. We also can't forget to mention cystic fibrosis because that affects the lungs. And you look at that and you say, well, why is it an E code? Well, that's part of the disease process, but it's a tightening and thickening of the lungs get fibrous is the best way to say that. These are E84 codes. So you can have with pulmonary manifestations would be a point 0. Then we also have a range for intestinal manifestations as well as other manifestations. We've identified what other stands for in the code set, and cystic fibrosis unspecified. Really, really good to become familiar with this particular disease process. I see that we have a person joining us from LinkedIn and they had a question. My providers use the two terms interchangeably and code document the two as they are the same thing. I harp on this constantly. COPD is not synonymous with emphysema. That is correct because COPD, now I have done some instructional education because I do provider education for them. This happens a lot with the primaries, not actually pulmonologists, and the cardiologists get it pretty good. But uh, the 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 thing of it is COPD. You can have COPD, but once you have emphysema, you don't go back to COPD, and that is about the best way to explain it to them is that emphysema trumps COPD. Pulmonary hypertension is kind of the disease process that we're going to wrap up with here. Then we'll get into some other meaty information. Pulmonary hypertension is not the same as hypertension, right? This is a pressure that's developing within the heart and the lungs, and it's the blood backs up, so it's not like your I10 codes, right? I10 through I13 codes. That's completely different. This has a relationship with the lungs. So you can have several types, primary, secondary, due to left heart disease. Now, if you have CHF and they determine diastolic and systolic, then that will be able to link the I27.22. But we can also have secondary to lung disease and or hypoxia. We can have thrombolytic, other secondary, and unspecified pulmonary hypertension. In this scenario, you probably wouldn't be using the unspecified for very long. It wouldn't take long and they would be able to identify what is happening. But there could be some underlying conditions that you've got to make sure that you capture if they're the cause, especially due to left heart disease, for example. And I put some of those in there. Polycythemia vera, essential thrombocytopenia, and sarcoidosis are just a few that you could mention or note. Now, this was a really neat graphic from the UK, and I didn't get in there and read the article too much, but ultimately what they did was they took two sets of cadaver lungs and they just pumped regular oxygen into the one lungs, and note that and they literally just plug this into the bronchial passages, the airway. The reason that set of lungs is nice and pink and red is because it's oxygenated. Otherwise, it would be gray. Just they're pumping oxygen into it, just as if you were breathing in real life. But the second set, the other set that's black, they they pumped in cigarette smoke and it turned black right away. Now, again, people who smoke are getting oxygen as well. And what I think they did to make this really, really black fast is that they didn't pump oxygen through that. They pumped cigarette smoke, so minimal amounts of oxygen, but it was a cigarette smoke that was going in there. And it darkened up those gray lungs already because of the lack of oxygen, and instead of them being nice and pink. So that shows you kind of an extreme example of how detrimental cigarette smoke is to the lungs. And that's why you see those exposure codes listed with all pulmonary type diseases. So, what are some of the medications that we would look for and have on our patients' med list that we could link and show their treatment for their lung disorders? These are terms that you need to become very familiar with. Now, you're not going to get HCPCS codes off of these most of these because you can't do pills or inhalants, and most of these are inhaler type medications, bronchodilators and things. Although I wanted you to be aware of some of the common ones, and you can even see them often on COPD commercials, right? If you see those. Um, yeah, and Jane is asking, does vaping cause the same thing? Actually, yes, it's worse from the information and research that I've done and what the providers are saying in their documentation, because the vaping is actually putting elements into the lungs, meaning metal and stuff into the lungs. Uh, let's see. Uh, Jane says, aren't we to add current or past history, smoking history, if any respiratory disease, if a patient's in the medical record? Absolutely. If the provider uh, yes, you do. Now, if you're dealing with a respiratory diagnosis that the patient's being treated for that encounter when you're doing prophy coding, right? Your outpatient codes, then if the doctor or your provider mentions that history of, uh, you will append those codes. So absolutely, that is correct. Real quick, talking about CPT codes, if you're going to do a breathing treatment on the patient, then you're going to start looking around 94640, and that is a breathing treatment, and that's where the codes start on those nebulizers. You see those a lot in the ERs as well. Very common for children to have breathing treatments that's when they have asthma, but sometimes your COPD patients, when they get into an exacerbation, they'll give them breathing treatment. So I wanted you to be aware of that code to start to launch your research. The short-acting bronchodilators, albuterol is probably the most common one that you hear about. It comes in liquid as well as an inhalant. I think I'm pretty sure it even comes in a pill. But Atrovent and Xenoxpin, no, let's see how I can't remember how you say the X, but Penex, Cypenex. Um, it will levobuterol is you'll see that in the documentations. It's easier to say. These are very common, and those are just quick opening up the lungs very quickly. You'll often hear albuterol used as the rescue inhaler. I keep an albuterol inhaler in my purse at all times because you never know if you go in somewhere and there's like real strong candle smells or somebody's perfume, anything that would exacerbate a person that has asthma. I haven't had problems for a very long time, but It is a rescue. It's short acting. Open those lungs up real quick and dilate everything so that you can get some air in. Examples of long acting bronchodilators, that's different. And these are some of the newer ones. Uh, Spiriva, you see advertised a lot. And that is probably, I think, the one I hear about the most is Spiriva. Again, there's just means that they stay in the system a little bit longer. Now, if you are going to show someone how to use the inhaler, you're doing education for teaching somebody how to use their inhaler 94664. Thought you might not have been familiar with that. That would be used when you're, onboarding a person with a new diagnosis, most likely. Inhaled steroids. The first two, Flovent and Pulmicort, these are ones that often, those little liquid dispensers that get put in the nebulizer, but they also come in an atomizer. But again, those are two that you see put in nebulizers. And I'm not going to go ahead and read all of these, but I wanted to bring some of them to your attention. Trelegy, I see that advertised a lot. Symbicort is advertised. I actually have used Advair in the past. When there was like 3 or 4 years that I really, my lungs were taking a beating, and I had a lot of exacerbation, but I've been off of that for a long time. But Advair, very common. And these are long acting and they have a steroid included. The first two are by themselves. One, Flovent and Pulmicort, are by the medication by themselves. But all of the rest after that are to the left, those are actually combo drugs. So they have more than one thing in them besides the steroid, or maybe two kinds of steroid. Keep that in mind, and you may recognize some of these. Since I have not had as many of the complications as I used to, I don't stay on top of it because I haven't been doing a lot of pulmonology recently. So it's good to have a refresher. What kind of diagnostic studies are going to be done for your patients to determine they have asthma? Do they have COPD? What levels of COPD they have? What part of the lungs is the emphysema? Is it centrilobular, panlobular, things like that? The first one they'll do is this spirometry and spirometry. There's several ways to say that, and I usually butcher it, but ultimately that's a breathing test where they plug your face up and stuff and make you breathe for long periods of time. Exhale as long as you can and things, and they study the force that you're able to do with your lungs. You can do a chest X-ray. Man, that nails it. Yeah, I see a lot of diagnoses captured off the X-ray. CT of the lungs is, I would say, that is the go-to. They may do a chest X-ray, say, "Hey, we see something. This is what we're going to, this is a diagnosis, the diagnosis, but we need to do a CT of the lungs to see what other type of disease process is happening." And that's very common. And then they can do your ABGs. Now, what they do with it, that's arterial blood gas. That isn't just a regular blood draw. They actually do that. Well, they can do it in different places, but when they used to do them in the ER, they stick a very long needle straight into your wrist. And you know where you feel your pulse? That's where they're going to hit it. They're going to hit your artery and your wrist and literally check to see how much oxygen's in your blood at that time. Um, Symptoms of COPD, I wanted to add that because when you have a diagnostic test done, there has to be a reason for the diagnostic test, and they will list the signs and symptoms if they don't have a definitive diagnosis yet. So why would you have a diagnostic test? Because we don't have a definitive diagnosis. And the different terms that you're going to see, which would be these would all be R codes for signs and symptom codes. Your hypoxia, shortness of breath, dyspnea, wheezing, persistent cough. We got sputum production, chest tightness, hypersomnolence, meaning you fall asleep during the day. And the all as many as is applicable will be on the order, and that'll be on the test. When the test is it comes back and the report's written, it'll say what were the symptoms or indications for the diagnostic test. So you need to be familiar with that, uh, because once you have a definitive diagnosis, then you're going to drop all those signs and symptoms. That's the way we do it in Pro V, and that's ultimately why we're doing the diagnostic test, to come up with a higher specificity of the determination of what the disease is that the patient has. Note too that for additional support, you may have a patient that's reliant on oxygen. uh, when you have a pulse ox that the patient's consistently under 95, that's a problem. We want to see them at 99 or 100%, 98. But when you start dropping below 95 and they can't get that back up, then they'll start running other tests like chest X-rays and the spirometry test to see what's going on, and the additional support for having a diagnostic test. What about complications? Now, this is important because I alluded to this a little bit ago when I stated that you can have problems with the lungs. You can have asthma, COPD, emphysema, and some like bronchiectasis and things. But when you have complications like that and they're chronic and long term, then other body parts start wearing out or having complications. And common one is frequent respiratory infections. Your little coding spidey senses should go ding, ding, ding. That makes sense because there's a code for COPD with lower respiratory infection, right? So that makes sense, I'm sure, to you. We will see that our patients can't get proper air in and out, and fluid builds up a little bit. And what happens when you have fluid buildup in a warm, moist, dark spot? You're going to get infections. Heart problems, you will see arrhythmias, you'll see CHF, you'll see the embolisms and pulmonary hypertension. Yeah, patients can even have MIs. So again, heart problems. It it Think about that. Those lungs are kind of wrapped around that heart, and if the lungs start having problems, the heart is directly affected. Lung cancer is, think about those cells. Anytime you have cells that are constantly being irritated, then for whatever reason, then they're going to start to morph a little bit, right? And lung cancer develops commonly from these type of irritants. That's one of the reasons cigarette smoke is so bad. It's an irritant to the lungs. High blood pressure in lung arteries, and that's where we get that pulmonary hypertension and depression. If you if you have ever been around a person that had emphysema, COPD not so much, but emphysema, they're cranky people. And it's not that they're just mean people, but when you can't get air in and out, you're cranky. It just is it's just true. Plus, that depression, you're not getting enough oxygen to the brain. You don't feel good. It's probably not going to get better, right? COPD, once you get COPD, it doesn't go away. And so there's a lot of dynamics. You can't do the things that you used to be able to do. So depression is very common. Pay attention to that and that linkage between the disease process happening and depression on the side. So, I wanted to make sure that was brought up. Any questions? I think you guys have been doing great. Let's see, uh, Jennifer wrote a question, said, if you use 94664 only used once per patient, my thinking is providers should not be paid twice to repeat themselves. Well, um, there is some information when you go look at that code itself. There are some guidelines and about using that, but yeah, you're right. They're in one day. You got to be careful. Yep, they don't do repeat stuff. Very good. Is there a diagnosis for someone with one lung? Is it genetic or is it there is a code for acquired absence of a lung? Yeah, there is. And if you ask me what that is on the top of my head, I can't tell you. But if they're born without a lung, it will be a Q code. If it's an acquired absence of an organ, then it would be a Z code, um, and it would be right there close to those BKA and below the knee amputation codes, which oh gosh, I was just I deal with those all day, but they run in my head. Is it Z79? I think is you start looking in those. Does vaping cause same thing? Vaping does cause asthma, COPD, and irritants. In fact, it's very pertinent to think about this, guys. You know when they put in for in the middle of the year the U codes for COVID. They took the opportunity to kind of piggyback those vaping codes. That was that was pretty amazing. Now, the dynamics of adding new codes and what codes are added, that's a long process. But I was shocked when they added the U codes for vaping in with COVID codes. It had nothing to do with vaping and COVID involved with COVID patients. It was like they piggybacked those codes in. They needed to be added anyway, and there was no codes for them at the time. And it has been on the agenda for a while to have codes related to that in more specificity. We've had a code that we could use, but it wasn't specific. It was an other code, and so that was pretty cool to have that. That's not game changer. I'm not trying to think of the right verbiage to use. That was a big deal, guys. A really big deal. Uh, and at the time we were overwhelmed with COVID itself. We really weren't paying that much attention. But in retrospect, think about that. They don't, first of all, they don't add codes in the middle of the year, and now they're going to do that routinely. They've done it again, and for the COVID, we may understand pandemic, but to why vaping codes? Why couldn't they have waited till the end of the year? So they are tracking it because it is very, very harmful that they're seeing. Now, I'm not going to get a soapbox and tell you all the details. You can go research it yourself. But there's all kinds of things that we put into our body that is not good for us, that is legal and illegal for us to do. But the scenarios that are coming into the ERs and the damage that's being done, especially to young people that are involved because they think it's just like steam. So, yeah, good point to bring that up. Don't forget that if you want to know when we're doing our live events, you can find out by going to cco.us/notify. If you're watching us on YouTube, you can click that little bell. You can subscribe. You'll be notified. If you're watching us on Facebook, you can like it. And if you're following us on LinkedIn as well, you'll get notified of live events, but the best way is to go to the notify. Also, wanted to bring up the point that if you have a topic request, something that you would like for us to flesh out, unpack, give some education on, then let us know by going to the cco.us/topic hyphen request, and we'll absolutely get that ready for you. We are wanting to plan something special because our next club event will be number 100. Okay, guys, thank you. Oh, one more question. It says, MG says, is it possible to code emphysema, COPD, and bronchitis together? Well, no, there is a trumping system there. So emphysema is a type of COPD, right? So you would code for emphysema if a patient had all of that. Bronchitis, though, is different than emphysema. So you wouldn't code COPD. You would use the emphysema code and the bronchitis code. You could do both of those. It's two different organs within the system. Hi, Pansy. Good to see you. All right. Thanks, guys. Appreciate you joining us. We'll see you next time. Happy learning.